All right, we're going to go ahead and get started. I'm going to change everyone's layout now.
Thank you. Good afternoon, everyone. Let's go ahead and begin our webinar. Welcome today to the webinar facilitated by the National Alzheimer's and Dementia Resource Center, formerly the ADSSP Resource Center. The National Alzheimer's and Dementia Resource Center consists of our team at RTI International. I'm Sari Schumann with the Resource Center team, and I will be moderating our webinar this afternoon. The purpose of these webinars is to provide helpful, current, and applicable information for ADSSP and ADI grant projects and others in the Aging Network. Please note that the webinar today is being recorded. At this time, I'd like to turn it over to Erin Long from the Administration on Aging, Administration for Community Living to provide a brief welcome.
Hi, everyone. I want to thank you for taking the time out of your schedules to attend our webinar, technical assistance webinar on Alzheimer's disease in hospital and emergency department use. We're very excited to learn more on this topic and are thrilled that Dr. Wiener and Dr. Feng have made time to share the results of their studies with us. This is I just want to put a advertisement out that this is the first of what should ultimately be 12 webinars between our Alzheimer's disease programs over the next year, and I hope, it seems like we're off to a great start. So thanks for coming, and I hope you enjoy and get as much out of this as we believe you will. And thanks, Sari. I'll turn it back to you.
Thank you. So as you all know, today we'll be hearing from Dr. Josh Wiener and Dr. Zhanlian Feng. They will be speaking today about their work related to hospital and emergency department use by older adults with dementia. Josh Wiener is a distinguished fellow and co-director of the National Alzheimer's and Dementia Resource Center at RTI International. Zhanlian Feng is a senior research analyst in the Aging, Disability, and Long-Term Care program at RTI International as well. We welcome and thank both of you for your presentations today. We will allow time for questions through the webinar's chat feature at the conclusion of their presentations. At this time, I will turn it over to Dr. Feng.
Thank you. Thanks for the introduction. My name is Zhanlian Feng. As introduced, I'm a senior research analyst in the Aging, Disability, and the Long-Term Care program at RTI. So this research I'm going to present today is a collaborative work with several of my colleagues at RTI, including Laurie Kuz, Jania Kaknova, and Josh Wiener. I hope everybody can hear me well. So this study was funded by the Office of the Assistant Secretary for Planning and Evaluation under DHHS. So I just want to note that the findings I'm about to talk about are actually published already in the April issue of Health Affairs, just in case you are interested in reading the full article. Also, the project report is posted on the ASB website as well. So let me give you a quick background for this study. As we all know, Alzheimer's disease and related disorders affect more than 5 million older Americans, and the number is projected to triple by 2050. So the actual prevalence of dementia might have been higher than reported, because many people with cognitive impairment are not diagnosed. That is a known fact. So the disease poses really substantial burdens, emotionally, physically, and financially, on individual patients, their families, and society. So one important source of such burdens is frequent hospitalizations and ED visits. These encounters are disruptive costly and particularly challenging for people with dementia because of their poor communication abilities and coexisting medical conditions associated with dementia. Older people with dementia also have special difficulties in transitioning across care settings. Therefore, unnecessary or potentially avoidable hospitalizations and ED visits have very important implications for the quality of life and, of course, quality of care as well for people with dementia. So there's a growing body of research on this population, but few studies have focused on hospital and ED use, much less on potentially avoidable use of such services among older people with dementia. Also, we've seen a lot of studies in the past which really is concentrated in the nursing home setting, but a few that look at the impact of dementia on hospital use in the community and at the end of life. So the purpose of our study is to examine whether there are differences in hospital and ED use, both overall and potentially avoidable, between Medicare beneficiaries with dementia and those without dementia. So we did this both across settings, either in the community or in nursing homes, and by proximity to death, using data for several years before death and during the last year of life. So the hope is to provide a more complete picture on this issue than was previously available. So in this particular analysis, we use 5 waves of the health and the retirement study data and merged that data with the Medicare claims over the period from 2000 to 2008. So conducted by the University of Michigan, the HRS is a nationally representative sample of older adults who are interviewed every 2 years. So our study population included HRS respondents who age 65 and older and who are fee-for-service Medicare beneficiaries, and also who agreed to provide data of their Medicare claims. So altogether, we have over 12,000 people with more than 39,000 observations that met all of the inclusion criteria for this study. So we conducted separate analysis using 4 subsets of the sample, which includes community living residents, nursing home residents, community decedents, and nursing home decedents. On the next slide, I'll talk about the variables. So from the linked Medicare claims, basically hospital inpatient and outpatient claims, we defined 2 sets of outcome measures, which are dichotomous, yes, no, to indicate whether a beneficiary had any hospitalization or any ED visit. For each, we made a distinction between overall utilization and potentially avoidable use. So the measurement period for each outcome was a calendar year in which the HRS survey was conducted. For decedents, the measurement period was the last year of their life. To define potentially avoidable hospitalizations or ED visits, we used the list of conditions and associated ICD-9 codes identified by ED Wash and colleagues from RTI in their earlier study on hospitalizations among the dual eligible beneficiaries. So there are a lot of details there I'm not going to go over, but they are available in the paper as well as in the reports. So to identify people with dementia, we used diagnosis codes for Alzheimer's disease and related disorders from the Medicare claims. In conjunction with a HRS survey-based measure of severe cognitive impairment that is consistent with the dementia. This is because dementia diagnoses are not available in the HRS survey. Nevertheless, the cognitive impairment measure there has been validated using diagnostic data by other researchers. And other than dementia, we also included a comprehensive set of risk factors for hospitalization or ED visits, which are not detailed here, but again are available in our paper and report. So in our analysis, the person is the unit of analysis for all of the outcomes defined. So what we did is we conducted multivariate regression analysis separately for each of the 4 subsamples, as mentioned earlier. So the purpose of multivariate analysis is to trying to estimate the net effect of dementia on each outcome independent of other risk factors in the model. Also of note, all the analysis and the results I'm going to present were adjusted using the sampling weight. So that could be a representative of the national population, of the underlying population. For the 6th time, we're not discussing further detail regarding the methodology here. So let's move on to what the results. Here you see a bar chart here. So the cluster of bars on the left-hand side of the graph shows that the prevalence of dementia was about 7 times higher among nursing home residents, which is 84, than among community living residents, which is about 12%. So the overall prevalence combined is about 15%. Among the decedents, as shown in the bars on the right-hand side, dementia was more common. 44% of all decedents, 87% of nursing home decedents, and 34% of people who died in the community. Now, the next slide summarizes our key findings. So instead of showing you all the nitty-gritties or the regression parameters or model other specifics, here what we did is we calculated the regression adjusted percentage of people who experienced a particular outcome. For example, whether that person had a hospitalization, by whether they had dementia or not. So this is done separately for the 4 subsamples, as I mentioned earlier. So let me walk you through each of them. I apologize if the numbers appear a little small from your end, but I hope it works. So the horizontal bar graph on the upper left corner of the slide shows the adjusted percentages of people who had any hospitalization, any potentially avoidable hospitalization, or any ED visit annually over this period among the community living residents. This is our subsample number 1. So the red bar is for people with dementia. The blue bar is for those with no dementia. So you can visualize the differences between these 2 groups. For example, the top pair of bars shows that nearly 27% of community living beneficiaries with dementia were hospitalized each year. This is higher than the 19% of those without dementia. So the middle pair of bars shows that about 8% of people with dementia had at least 1 potentially avoidable hospitalization, which is also higher than the 5% of people who did not have dementia. So the pair of bars at the bottom indicates that about 35% of community living residents had AED visit, at least one each year. While here, regardless whether they led to a subsequent inpatient admission or not, we just look at all the types of ED visit here. Again, which is higher than the 25% among those with no dementia. We found all of these differences I just talked about are statistically significant. Now, let's turn to nursing home residents, as pictured in the lower left corner of the slide. So here we see that among the nursing home residents, the difference between those with dementia and those without dementia was not statistically significant for any of the utilization outcomes. Nevertheless, if we compare this bar graph with the one just above it, I just showed you a moment ago, you can see that regardless having dementia or not, nursing home residents in general are hospitalized and had ED visits a lot more frequently than people living in the community. Now, let's look at the decedents during their last year of life. So among the community decedents, as just shown in the upper right corner of the slide, we observed no statistically significant difference between those with dementia and those without dementia in any of the three outcomes chosen. By the way, we have several more outcomes in the paper, which is to pick a few here for the sake of space is sufficient for illustration. However, now if we compare this this graph with the one to its left, that is the very first one, the one for community residents, you can see that regardless of having dementia or not, a substantially higher percentage of decedents from the community were hospitalized or used the ED during the last year of their life than among the overall sample of community living residents. Most of whom, of course, are many years away from death. Just to give you an example, about 78% of community decedents with dementia were hospitalized during the last year of life, compared to 79% of those without dementia, about equal. Now, the last figure on this slide, among the nursing home decedents, in the lower right corner of the slide, we found, again, no statistically significant difference in any of the utilization measures we look at here in the last year of life between those with and without dementia. Now, there are several interesting ways to compare all these charts. I know it's a little bit busy, but hopefully I did the job walking you through. So if you want to compare this paragraph and the very last paragraph with the one to its left, we can see that the rates of hospitalization and ED visits among nursing home residents increased sharply, very strikingly, during the last year of life. Just compare how long the bar is. So we can also compare this graph with the one just above it, right? So see, among of all the decedents, you can see that during the last year of life, really the utilization patterns became remarkably similar, very high, both places, regardless where people died or where people died from the community or nursing homes, or whether they had dementia or not. So altogether, these results suggest a convergence in hospitalization and ED use over time in a way such that the gap in utilization between the two groups, people with dementia and those without dementia, really diminished in the last year of life. So in this graph, we illustrate this pattern, which shows the percentage of community decedents who were hospitalized, who were ever hospitalized during each of the 5 years before death. By the way, we observed a similar pattern for ED utilization as well, but we did not show here. So just to recap, in this study, I think the results suggest several key findings which have important policy implications. So first of all, we found the impact of dementia on hospital and ED use varied by a residential setting. Specifically, among the community living Medicare beneficiaries, people with dementia were significantly more likely than those without dementia to be hospitalized and to visit the ED. So this may be attributable to many factors. For example, there may be inadequate primary care and other medical care services in the community to such patients. In addition, we know that there are very few programs that are specifically designed to reduce hospitalizations among community residents with dementia. In contrast, we found no significant differences in hospital utilization among nursing home residents by whether they have dementia or not. We know that most nursing homes are equipped to provide medical and nursing care, and in many homes, rehab care for many conditions, which would be difficult to manage in community settings. Also, we know that in nursing homes, there's a very high prevalence of dementia. So given that, providers may be more used to treating patients with dementia than our community-based physicians. Second, we found hospital and ED use by people with and without dementia converged during the last few years of life. So in the community, we saw that people with dementia were hospitalized or visit the ED more frequently than people without dementia for several years before death. But these differences in utilization actually diminished as death neared. So we suspect one possible explanation for that is dying is becoming such a difficult and a complex process for all people living in the community, right? So approaching death may have overwhelmed any differences in your cognitive ability status, resulting in a similar rate of hospitalization and ED visits. I also want to emphasize again, there's a very sharp rise in hospitalizations in the last year of life for beneficiaries in the community. Is really striking compared to years ago, years away from death. So there's sharp rise there. We found substantial proportions of hospitalizations and ED visits are potentially avoidable, which have implications for their quality of life. So we know this is a policy concern and also indicates a potential opportunity to achieve cost savings for Medicare and other payers as well. Lastly, these findings really underscore the importance of providing supportive services and advanced care planning for older adults with dementia long before the death, so especially for those living in the community. Doing this, we believe, could avoid unnecessary hospitalizations, which not only improves quality of life, but also saves money. Of course, these studies have limitations. For example, we only look at fee-for-service beneficiaries because the managed care people, we don't have claims available. So that our dementia definition could be an issue as well, depending on how you would approach it. There's no gold standard for that. There is ample room for misclassifications, despite all the efforts we made. Also, the definition for potentially avoidable ED visit is not validated. We just use the same conditions in defining potentially avoidable hospitalizations to define potentially avoidable ED visits here. Of course, we also there might be potential bias due to sample attrition if this is a longitudinal study, but we from our analysis is very minimal. Future research, I think there are several areas that's worth investigation. For example, including a examination of the impact of several policy initiatives, right? With the goal to integrate acute and long-term care for older adults, especially for people with dementia, which is not in there yet, not the focus yet, but this is becoming really important. And we know the managed care is growing in both Medicare and Medicaid, and looking at their utilization patterns is becoming very important as well. Another factor is hospice. In this study, we were not able to look at it, the relationship between hospice utilization, last year of life, and overall hospital transfers, which is a very important factor as well. I will stop here, and after Josh's presentation, I'll be very happy to take questions and discuss with you about hear your comments as well.
Thank you so much, Dr. Feng, for your presentation. We'll turn it right over to Dr. Josh Wiener for his presentation, and then we'll move into questions and answers.
Thanks, Zhanlian and Sari. So I'm going to be talking about the effect of dementia on hospitalization and emergency department use in residential care facilities. So these would include assisted living facilities, but it's certainly much broader than that. As with the other study, this project is funded by the Office of the Assistant Secretary for Planning and Evaluation, and the views expressed are those of the authors and not necessarily those of ASPE or RTI International. As with the other study, this was done as a collaborative effort. In addition to Zhanlian, Lori Coots, and Ruby Johnson did analyses for the study, and we want to thank Emily Rosenoff at ASPE, who was our project officer. So Zhanlian already has discussed that people with Alzheimer's disease have high healthcare costs and utilization, and that hospitalizations and emergency department use is of particular concern because people with Alzheimer's disease don't do well in the hospital and don't do well at the emergency department. Those services are not really well designed for people with dementia. But as Zhanlian pointed out, little is known about the impact of dementia in various settings, and certainly that's true in residential care facilities. In doing this analysis as part of our literature review, we only managed to find one study in the last 10 years that had looked at that. So we're trying to fill that gap, and we're doing that by asking two research questions. One, does having severe cognitive impairment affect the risk of hospitalization and emergency department use among residents in residential care facilities? And the same question for emergency department use. And then We're also looking at whether living in a dementia special care unit or a facility that only serves people with Alzheimer's disease affects the risk of hospitalization and emergency department use among RCF residents, and also the number of emergency department visits. Um, there's been a large rise in the number of dementia special care units in nursing homes as well as residential care facilities, and they have always been very controversial. They typically charge a lot more than usual care, and at least historically, studies have not found much of an impact. Um, Many of those studies focused on nursing homes and not residential care facilities, and many of those studies were done 10 years ago or longer. And so the question is there an extra something that goes with living in a special care unit? So the data source is different than the one from the earlier study. This is using the 2010 National Survey of Residential Care Facilities, which is a national survey sponsored by the Office of the Assistant Secretary for Planning and Evaluation, the National Center for Health Statistics, and other federal agencies. And in order to be considered a residential care facility for this survey, you had to have been licensed, registered, certified, or otherwise a regulated facility. You had to have at least 4 beds, provide 24 on-site care supervision, provide help with activities of daily living or some health-related service such as medication management, provide room and board, and at least 2 meals a day. And you had to have served basically an adult population. Importantly, facilities that exclusively served people with intellectual and developmental disabilities or severe mental illness were excluded. So we have a large slice of the residential care population. We don't have everyone, but we certainly have the facilities that are mostly focused on older people. So the survey interviewed facility staff to gather information on the facility and, importantly, the residents. No individual residents were interviewed for this survey. We gathered information on residents by asking the staff about them. So we collected data on 2,302 facilities and over 8,000 current residents. As NCHS tends to do, they got very high response rates at the facility level, 81%, and at the resident level, given that we got into the facility, 99%. And we basically used data from both the facility level and the resident level that we merged together at the Research Data Center with NCHS. So since the study population is about Alzheimer's disease, we restricted this analysis to the population age 65 and older. And so we ended up with about 6,444 unweighted people, representing 612,502 residential care facility residents nationally. So I think it's important to note that this is almost half the size of the number of people in nursing homes, which I think underlines the growth in the RCF population over time. We also added in a variety of facility and local market characteristics having to do with the supply of hospitals and nursing facilities. And as I've already mentioned, we did this work at the Research Data Center. So in terms of key variables, in terms of the hospitalizations, the dependent variables, we had three major ones. We looked at hospitalizations, whether or not the resident had any over the last 12 months or since admission. We looked at whether or not they had any emergency department visits over the last 12 months or since admission. And we looked at the number of ED visits over the last 12 months or since admission. Unfortunately, the survey did not have any length of stay or number of hospital days for that component of the study. So in terms of defining severe cognitive impairment, we considered people having severe cognitive impairment if one of two things happened. One, on the survey, they had a diagnosis of Alzheimer's disease or dementia, or whether the staff reported that they had 3 of 7 memory impairments, confusion, or problems with orientation. And so those are things like whether or not they know where their bedroom is, whether they can recognize staff, whether they know that they're in a facility, and whether they know what the season is. And then we also have a variable about whether people are living in a special care unit or whether they live in a facility that only serves people people with Alzheimer's disease. And then we had a large number of control variables. I won't take time to go through them, but we had control variables at the resident level, the facility level, county level, and we also included variables on whether or which state that people lived in. So all of this was designed to make sure that when we did our regression analysis, we did not attribute to the dementia or the severe cognitive impairment variable things that explanatory power that should have gone to these other control variables. And so well, we did some descriptive analysis, but we also basically did some multivariate regression analysis, which I'm going to report here as odds ratios. And so the way to interpret an odds ratio is if it's more than 1, then there's an increasing risk of the dependent variable occurring, and if it's less than 1, then there's a reduced risk of the dependent variable occurring. So here we're now coming to the results. This is the frequency of hospitalization and ED use. These are just straight descriptive variables. About a quarter of all residents had a hospitalization. A little more than a third had an ED visit. We found about half of the people in residential care facilities met our definition of severe cognitive impairment. Didn't have much difference in the simple analysis in terms of hospitalization and ED visit use. There was a little bit of difference, but not a whole lot in terms of hospital use among people who were in a special care unit or a facility only serving people with Alzheimer's disease. Okay, so now we get to the fun stuff. So we ran 2 models, one where we just included severe cognitive impairment, and one model, a second one, where we included severe cognitive impairment and whether the resident lived in a special care unit or these facilities that only serve people with Alzheimer's disease. So what we found is that in the first model, having severe cognitive impairment did marginally significantly reduce your risk of having a hospitalization. So this was only significant at the 0.10 level, generally not enough to meet the standards of most journals of something as being statistically significant, but at the edge. When we added the special care units to the equation, the severe cognitive impairment variable, while still finding lower risk of hospitalization, was no longer even marginally statistically significant, but the living in a special care unit was very significantly significant, and the value was quite large. So being in a special care unit reduced your risk of hospitalization by nearly 30%. So here's the same kind of analysis for emergency department use, and we got almost exactly the same estimate levels. So very, very similar results. We also looked at the number of emergency department visits in the last 12 months, and what we found was that for severe cognitive impairment in Model 1, that there was some reduction, about a 7% reduction in the risk of hospitals, the number of emergency department visits. But we got a little bit different results in Model 2. Severe cognitive impairment stayed statistically significant, again, reducing the number of emergency department visits, but the special care unit did not become statistically significant, even at a marginal level. So as with all studies, there are limitations. These are reports by staff. We had no claims data. We were not able to identify potentially avoidable hospitalizations because we couldn't link to claims data. Others might quibble with our definition of severe cognitive impairment. There is no gold standard on that. And we had only limited data on hospital use. So I'm having a little trouble here. Okay, so this is the summary of what we found. Basically, nearly a quarter of RCF residents had at least one hospitalization, and more than one-third had at least one ED visit in the last 12 months. Being an RCF resident with dementia, those were less likely, with marginal statistical significance, to have any hospitalization or ED use, and to have fewer ED visits. However, the effect of dementia on hospitalization or ED visit is no longer significant when the residents in the special care unit or living in an Alzheimer's only facility is entered into the equation. Among RCF residents living in a special care unit or facility that only serves people with Alzheimer's, that decreases the risk of hospitalization or an ED visit, but it doesn't affect the number of ED visits. So that's basically our finding. Again, I think these hospitalizations and ED visits among people with severe cognitive impairment are a major policy concern. People with dementia appear to have somewhat lower odds of using hospital and ED use in residential care facilities. And the interesting thing is that the special care units and the facilities only serving people with Alzheimer's disease seems to be the main mechanism for lowering that use. So we don't know how that works, though. Knowing the adverse outcomes of hospitalization may mean that the staff are less willing to use those kinds of services because they know bad things happen there. Maybe maybe people with Alzheimer's disease in those facilities are more likely to have advanced directives that call for not sending people to the hospital. We don't know. So it's still a bit of a black box, but it does seem to be a pretty strong finding, and is particularly interesting because, as I mentioned at the beginning, most of the research on special care units has found that they have little impact, at least in the nursing home setting. So even with all the limitations, I think it's likely that given the adverse effects of hospitalization and ED use for people with severe cognitive impairment, anything we can do to reduce that use is likely to be a positive finding. So that concludes it. Thank you, and back to you, Sari.
Thank you so much, both of you, for your great presentations. I had a private comment come in that the information is fascinating, so I think that is great feedback for everyone. We hope that everyone found it very interesting. We're going to move into the question and answer session right now. And some of the information from people is already located in the chat feature. I'll repeat those questions, and we can move to the presenters for their responses. So one of the questions was there were two questions about abbreviations. Just to clear up for people, I can answer these. If FFS is fee for service and HRS is the health and retirement study. The other question, next question that came in was asking if the sample source was from Wisconsin for the second study that was discussed.
No, the National Survey of Residential Care Facilities is a national survey. So Wisconsin undoubtedly has a few folks in there, but the NSRCF is not designed for state-level estimates. The National Study of Long-Term Care Providers, which has continued by the NCHS to gather information on residential care facilities, has worked hard to be able to get some information on a state-level basis. And so I suggest that you look to the national study for long-term care providers for the state-level estimates.
Great, thank you. The next question was, what other diseases or diagnoses lead to Alzheimer's disease and the utilization of the emergency department versus admission?
Hi, this is Zhanlian. I'm not a clinician, so I don't know what factors might actually lead to Alzheimer's disease per se. But I do know that people with Alzheimer's disease tend to have a greater number of conditions, as we found out in our data. So we did control for those conditions in our model. And then what diseases led to utilization of ED versus hospitalization? I do have the very detailed results in front of me. For example, in predicting whether a person had a hospitalization, there are specific diagnosis conditions like lung disease, heart problems, stroke. What else? These are the few that's popping up in front of me that predicts hospitalizations. We also sort of adding up the total number, how many conditions altogether you have in the model, that showed up very consistently predicting greater odds of hospitalization and ED utilization.
Okay, great. There are a lot of questions coming in. This is great. We're gonna try and get through as many as we can. The next question was, did you obtain the cause or reason people were in the emergency department or hospitalized?
Well, Josh, go ahead.
Well, with the National Survey of Residential Care Facilities, that information is not available.
Okay.
In,
And go
in
ahead.
in the HRS data we analyzed, I don't think that very specific questions are available there either. We just relied on whatever the Medicare claims told us, what kind of diagnosis the patient had. That's the only information available. We don't know. We're treating that as the cause of hospitalization or ER use, but there are more, other nuanced the circumstances, which we don't know.
Okay. And could one of you define what an avoidable hospitalization is?
Right. So this is a very complex issue. There are a lot of studies trying to figure out under what circumstances hospitalization might be preventable. But unfortunately, almost all of the studies are sort of doing it only after the fact, retroactively, right? So that sort of really heavily depends on expert opinion. So whether they consider some conditions. For example, give you an example like a diarrhea or food poisoning, right? So you can imagine if you are living in a nursing home, those conditions should have been managed before you send people to hospitals, right? So that in that setting, that may be potentially avoidable. But for the same condition like acute diarrhea in the community, it may be arguable. How can I handle that situation in my own home, in the community without the kind of resources nursing homes have? So in that case, that may not be preventable. So that's really not an easy decision to make, I think.
So I think conceptually it tries to get, there's a huge literature on potentially avoidable hospitalizations, and all of which show that a substantial portion of hospitalizations, especially among the nursing home population, are potentially avoidable, and also among people in the community. And I think they're basically trying to get at two ideas. One is this a hospitalization where if the person had received good quality care in their previous setting, would they not have deteriorated to such an extent that hospitalization was necessary? Or if they did develop the condition, was it one that with good quality care could have been managed in the setting in which they lived? So as Zhanlian has pointed out, that last part can be somewhat variable in terms of where you're living. If you're living in a nursing home where presumably there are nurses at least somewhat available, they may be able to provide certain kinds of services that may not be available in the community. But I think the study that Zhanlian talked about in particular with both the very high hospitalization rate and the high levels of potentially avoidable hospitalizations in the community really kind of underlined the need to improve primary care for people with Alzheimer's disease in the community, because I think that what the data suggests is that when people start to go south, the community-based system has no way of coping with it. So the thing that the doctor does is they just ship the person out to the hospital or the emergency department. And that's, as we've said before, a formula for bad things happening.
Okay, the next question is, do you have any statistics on the differences in numbers between those that have a diagnosis versus those meeting the additional measures? Can any conclusions be drawn regarding the lack of diagnosis?
Yeah, I guess this speaks to the definition of dementia. Really, this is a very difficult area to come up with any consensus from, as far as I read the literature. Actually, in the appendix of our own paper, we compared the people who had a diagnosis as captured from their Medicare claims, right? And then among those people, compare that to the severe cognitive impairment score from the HRS. There's no perfect matching there. So that gave us some sense of this kind of discrepancies. There are other studies, including people using the HRS a lot. They're trying to validate, they're trying to compare that. I do not know where there's a strong consensus there. There could be biases either way. If interested, I can share more specific numbers. I simply don't have that on the top of my mind right now.
Yeah, I think the analysis that Zhanlian is referring to, where we basically compared the Alzheimer's diagnosis on the Medicare claims and the HRS measures, and found an overlap, but not a one-to-one correspondence, really kind of underlines the imprecision that a lot of these studies have to cope with. We just don't have a silver bullet, gold standard in terms of identifying people with Alzheimer's disease, especially in these kinds of studies.
Okay, we have quite a few more questions left. We're going to try and get to two more. The first is, are there Medicare or nursing standards around criteria on deciding when to hospitalize patients?
I think the answer is no, except that there are a variety of quality measures that Medicare is developing that do look at potentially avoidable hospitalizations, and they basically are diagnosis-related kinds of measures. So I suggest that people look to some of those measures.
Okay. And then I think this will be the last question. I will copy all the questions that remain and try to get them answered for those who have asked. But we will try to answer this one. Could we infer from the study that we should focus resources on community residents with dementia to reduce emergency department use and hospitalizations?
I think the answer is yes.
I would agree, because we know that the vast majority of people with dementia live there, and according to our results, there seems to be they are a lot more likely to be hospitalized than people without dementia in that setting.
Yes, I think it's really striking that there are a large number of initiatives out there to try to reduce hospitalizations, reduce potentially avoidable hospitalizations. But as near as I know, there aren't any, or at least very few, that are focused on people with dementia, despite their high hospitalization rates.
Thank you. We have reached the end of our time today on this webinar. Thank you very much to Dr. Wiener and Dr. Feng for your great presentations and responses to these many questions. Thank you to all the participants for your attention to the presentations and such great questions. We really appreciate it. And we look forward to having you all at our next webinar, which will be announced in the near future. So thanks, everyone, and have a great afternoon.
Thank you.
Thank you. Really appreciate it.